So now we're going to get to the meat of this, which is implementation. And you've heard a lot. There are 16 ACOV indicators. We could, on most of the talks that we've had today, we could have held a whole symposium. And it is, there's a lot in it. But the real challenge is, how do we move forward in primary care? And so again, the goals where the learner will identify aspects of dementia care which are supported by national quality indicators, will identify opportunities and approaches to improve dementia care within their practice, and then will identify methods to optimize team function within their practice. So there are a couple, that kind of brings us back to a couple of documents I have to talk about. The first is the evaluation form, and if you go down to numbers 8 and 9, on the activity content, you will find, based upon information you received from this activity, please list at least 2 implementations in your clinical practice of your new knowledge and or skills, and what degree of confidence do you have that you will implement this. I'm a skeptic about CME. I think it's a necessary but insufficient component to change clinical practice. And you have on the blue paper a QI form, a quality improvement form for dementia care. And so I'm hoping that we've certainly been working hard within the main general system to identify practices that are willing to pilot some work in this arena. And we definitely want to encourage and invite other practices to join us in this process. There are lots of challenges and barriers in terms of implementation of this within your practice. But again, we have identified through MedCaps, and that's really a function of their funding and their orientation, 3 of those 16 indicators to focus on. Those 3 being early detection or screening, if you decide to do that, and then further workup leading to the diagnosis, and referral to community-based resources. So it simplifies it a little bit, but it certainly isn't easy. So first of all, I did want to talk about team in geriatrics, and I think you heard me initially. When I actually started with this cartoon, I had the office team was much larger and was in the center, and as I've given talks over time and become coached by my colleagues and learned more about what is available, I've moved it to this small part. And as I commented before, if I see somebody in the office for a half an hour once a month, it's less than 1/1000th of their life. But the office team is important, and Sarah Hallen showed a slide of how I used an office team, and I'll come back and talk about that. But it's really certainly making sure that we're using all of the resources we have to maximize the care of these patients is critical. We've been over this, but the implementation of both a standardized approach and a QI link to help make sure that we're doing what we want to be doing within our practices. And I'll skip over those quickly. Early recognition and screening. So for the office team, case finding can be a very important component of it, and it's really a matter of raising the awareness of your staff and providers to potential signs. Sarah spoke about this a lot. I found the most helpful person in my office was the secretary, because she's dealing with insurance issues, rescheduling things on the phone, and very quickly will pick up with problems with executive dysfunction. And they really just need a high sensitivity to the concerns. Screening, there in the state plan, there are a set of 2 questions which are called mild cognitive impairment screening questions. And we're building those into a routine part of the annual wellness visit at Maine General Health. And they're basically just about memory and also about organization. So they're getting at the memory and they're getting to the executive function issue. And then with the mini-cog, you really have to decide who are you going to target, who's going to do the test, training and scripting. And the targeting issue is challenging. I certainly, for a while, we were doing it with the annual wellness visit, and I think a somewhat shared experience is that who do we do the annual wellness visit on? Well, it's really kind of clunky if you've got somebody with multiple chronic illnesses, and so you tend to be doing it to your healthy, new Medicare patients who know there's a free exam, and the mini-cog was really not, it was an annoyance and not particularly helpful. The ACOV indicators are built around what are called vulnerable elderly. That is a specific subset designed by a testing called the Vulnerable Elderly Survey 13. And what that does is it asks questions about perception of health, functional ability, age, and then if you score above 3, you're considered a vulnerable elderly. There clearly is an association with longevity and both morbidity and mortality. And but you start to get a point at age 75. That's an easy number to integrate into a practice. So we just started screening with the mini-cog everybody over the age of 75. It was just easy to work into the practice, and it's that kind of sort of practical problem solving you have to do. I trained my medical assistant to do that test. And so I think you can really strip that down. People have asked, okay, so then you get a positive on the test and the patients are going to be very nervous about it or upset. And the scripting that I used personally was, well, this is like high blood pressure. You know, we've got one value here that's a little bit abnormal. We really have to do more testing and more understanding to really figure out if there's a problem and then bring them back. But those are the kinds of practical issues that come up in integrating it. This website is really interesting. Ontario is putting on a province-wide approach to dealing with memory impairment. And this particular spot, this particular URL will bring you to some tools that they use and an approach. They actually have an algorithm on that website. And I think we've got that on being built onto the Lunder Dineen website too, so that you can click directly to it. But they do have some, they use a risk calculator. First time I've seen this, I could not actually find that this has been validated clinically. It sort of makes sense, but anyway, so they give a 70-year-old man a 4% baseline risk, and then for each additional risk factor, you're doubling it. So by the time this patient, who's a 70-year-old smoker with hypertension and diabetes, you've got a 32% risk of dementia. So again, another little tool you could look at for picking a population that you might want to screen. And then again, once you've done the screening, you've got these 16 indicators. You cannot accomplish all the work that we talked about all day today in a 20-minute or a 40-minute visit. You're going to need some team support, and you're going to need to break this up into multiple visits. So there's some models out there. There was an article, and I'm sorry I didn't reference this, but it's probably about 3 years old in the American Journal of Family Practice. And they were talking about a single provider doing this work and really breaking it up into multiple visits. You could probably do 2 or 3 at the 99214 level, and possibly a 99215 if you're spending a lot of time on counseling, so family there and based on time. You can use staff aid in data gathering. Another model that David Rubin had published and I referenced in my talks was with a nurse practitioner within the practice, assigned the responsibility of working up these issues, and making sure that they were compliant. And again, you can see in an academic geriatric practice with a nurse practitioner doing this, they got up into about the 58% level in terms of meeting the ACOV indicators for dementia. So this is hard work, and it requires persistence. And there they were looking at all 16 of the indicators. So that's a big task, and we're trying to narrow it down for this particular project to those 3. Active RN role, which was mentioned earlier. And there's a lot that a well-trained RN could do in terms of history gathering, algorithm for lab ordering, counseling, referral to community resources. We use RNs and an RN and social worker in our geriatric assessment team in our geriatric clinic to do a lot of this work. And so this is an attainable goal. We're working on some pilot this work within our practices, and we've embedded the MCI screening questions into the annual wellness visit, and I think we've decided that we can trigger that in about the middle of next month, just figuring out how to help practices then deal with the responses to this. Screening with the MCI questions and mini-cog by MAs, all patients 75 and older without an established memory diagnosis, is a step we will be taking in the pilot practices. And so there's training and EMR support to be built into that, and these are just, again, practical pieces. If there's a concern on the mild cognitive impairment screen or the mini-cog, they'll go to a next step. And we're having some conversation back and forth whether this will be RN or it will go to the provider, and we have to figure that out. And that's the beauty of doing piloting. You're just going to try to solve these kinds of problems. But when I had put the talk together, we were focusing on the RN, but it would be the same for an initial visit with a provider. We're building a template for history into the EMR, specific tests, primarily the Lawton-Brody IADL, the MoCA, and the PHQ-9, labs via an algorithm. And so what you can see here, we're being fairly concise in terms of, or fairly narrow in terms of who would get laboratory tests without the provider actually necessarily having to be involved. So they would have to have new cognitive decline and a MoCA score of less than 26 and functional decline on an IADL score, which is due to the cognitive decline. And so if all 3 of those are in place, then the basic lab tests that were discussed would be ordered. The imaging would not be ordered via the algorithm. And then also at that point, referral to care manager and community resources. So, this is just a snapshot of some of the work that we're doing and trying to put into place. Our particular EMR is not as flexible as others. I think when I'm at AGS, I see a lot of stuff on Epic, which seems to be more flexible. And I don't know, Heidi's gone through the trauma of changing to Epic, and but anyway, I think they're certainly they don't have built into them specific data language that is capturable, that is geriatric specific, and so that's a serious problem for us. So then it comes back to the primary care specialist, and they can review the history in labs, do the medication review, do the physical exam that we were talking about, and then it's their job to synthesize, what does this mean? And so there's sort of these levels, again, that Cliff was outlining, and is this dementia or is it not dementia? What is it? And then making a decision about management or referral. And I think, as I've mentioned earlier, we are oftentimes in our geriatric assessment clinic really seeing people who are on that line. Is it mild cognitive impairment? Is it dementia? As I hope you go out of this room with some sense that's not an easy question. But as a primary care specialist, we do have that ability to easily follow people over time and repeat the testing and both know their strengths and weaknesses over time. Then there are all these additional steps that somehow need to be woven into it. And again, the paperwork that you have on the ACOV indicators can give you the structure for that. I think I skipped two. No, we've talked about that. So the EMR can certainly serve as a tool. You can build reminders into the EMR. We are structuring these notes so that we can capture that. So we're trying to build in at each step elements that we can grab and search for. I used to use, and I'm encouraging people to use, if there's abnormalities on this test, to use this ICD-9 memory loss code. And in ICD-10, it will be exactly the same code. But that's, I actually was able to frame it as memory concern at one point, which was even perhaps less concerning to people to have on their problem list. But it's, you sort of need a flag there to remind yourself to follow up on it, and then to make sure that you continue to follow that and be concerned, aware of it. So we're going to be able to capture the referral to the nurse, to the community resources. So we've got data elements there that we can track. So the pilot is going to be a learning opportunity. It's going to be hard, but important work. I think in general, in geriatrics, we're at a point where there's a lot of good ideas and a lot of good things we can do. We do need to be able to boil them down to a point at which it is doable in primary care and actually makes a difference. A conversation that occurs when I go to meetings is sort of a conflict between a public health approach and a traditional medicine approach. So a traditional medicine approach would say, those are the ACOV indicators, and you're going to do them all, and you're going to do them all 100% of the time. And a public health approach would say, if we move the ball on this a significant way, we'll make a difference on the population as a whole. And this is that latter approach. So I really want to thank you all for coming today, sticking with us through a long Friday, and I would urge you, if you're not affiliated with one of our 3 institutions, or even if you are and haven't decided about piloting, to let us know if you're interested. We'd be more than willing to work with practices outside of our institutions. This is the Office of Aging and Disability Services is a state of Maine funded organization, and we're definitely willing to share ideas with you and learn with you. So please let us know. Our emails are here on this last slide, and you were a great audience, great participation. Thank you very much.